Uh, since I'll just give a brief about the organization so you'll be able to relate what I'm trying to speak. Uh, it's a program called Care Health Mission. It's done by K Foundation, which is a foundation arm of Care Hospitals Group based in Hyderabad. This program has been done for the last 5-6 years with the basic idea, what you have heard from the other speakers. The idea is to approach from a different way and see whether we'll be able to achieve the healthcare delivery goals. What we have seen is that in the presentations from the respected speakers, what we have seen is the most important factor boils down to healthcare delivery. You have enablers in terms of IT and other things. But how robust is the healthcare delivery system and how are your outcomes actually coming out? I think these are the most important and how they address. So we started working on the model and trying to come out how actually it starts impacting. So this is a brief about what actually the objectives of the solutions which we are looking as part of our program. Is a one, it needs to be effective, it needs to be efficient, it needs to be sustainable. So we are not looking from a donor-based or a charity-based program, but we're looking, can we make it sustainable so that then it goes actually scales up across places, and how we actually can we re-engineer and bring around those models into place and bring all these objectives in place. So what we have done is that basically I'll just give a brief about the model. What we are doing is that we go through a model where, if you see, is that a health worker is being done at the village level. So you train a woman from the village to become a health worker in the center. And with the community participation, which is most important in doing all these programs, by actually the community itself gives space, table, chairs, and everything in terms of reaching the healthcare to those places. So the community participation, bringing the women from that village and actually having a health worker round the clock will help in actually solving one of the problems. So the delivery model is like, first is to bridge the community. First is that unless and until you don't have community participation, nothing works. So bring in the community, engage with a health worker, and the health worker basically talks to a remote doctor, could be based anywhere. It could be Hyderabad, any location, but try to address the basic problems. So we had is that how much of the problem could be solved on the primary care level. With the data of our work from the last 4 years, we can say very based on the data is that you can solve up to 70% of primary care problems into the most common problems of cold, cough, fever, malaria, upper respiratory infections, and lower basic problems, which are top 5 to 10. 70% could be treated then and there itself without any further intervention, just by having one remote doctor with health workers to a community. We are doing with 50 of those in Maharashtra program. So effectively what you're seeing is that you'll be able to reach to a lack of population with a group of health workers with 1 or 2 remote doctors. And the 30% of the cases which you can't treat or advise over the phone to the health worker, it goes to the primary health center which is based at the town. And from the town level, where actually the medical officer who treats, you have a percentage 1 to 5% who actually get hospitalized. Now you see is that the cost effectiveness of having a model which would reach of one doctor with a community of health workers and reaching the community efficiently. Yes, obviously to get this right, we believe the model should be into 4 parts, as like we spoke in speakers, is that it needs to be an integrated model. The first thing is that what we see is the training and the capacity building of the health workers. Unless and until the health workers are really strong and effective, you can't really bring around a change. So even the behavior change, what we're talking about, can happen only if you change the health workers as a change agents. And that needs to be done. So our training programs, and we spend 80% of our time only training programs of health workers into different areas. So they have home assignments, virtual trainings, to even actually visiting a primary health center 1 day in a month as a clinical rotation. So your emphasis on making them to understand how to diagnose a patient, how to understand, and all those things is very important. If they don't understand, the whole actually program collapses. The second part is the supply chain. So what we are seeing, lack of drugs, lack of things. Now that needs to be addressed. So how you supply the whole drugs supply chain management from your primary health centers, stock, or so on and so forth. Then you integrate all these data collections to the IT, the third vertical. And the fourth one is your health financing. Most of the programs don't look into health financing, and that's where high chance of the program being stopping or leverages is that interrupt or focus, so on and so forth. If you build in a health finance system and people understand there's a value for what you're giving, and at the same time understand is that you give to the right person. There's been a misutilization of, like, you take drugs, but they don't actually utilize for a dose of 7 days. They may take it, but they may not use it. But if you start putting value for it, then the right utilization is coming, and the utilizations on seepages, pilferage, all the things will come down. So the idea is to bring all these things to one platform and make an integrated healthcare delivery model, which could bring around, could be scaled up and looked at in other places. So currently with our programs now, currently we are placed in 3 states. We are in Maharashtra in a district called Yavatmal with 50 villages. We are taking care of rural villages in East and West Godavari, around 200 villages. We are running a primary health center in Kakinada. We are managing a 30-bed hospital in Orissa. We are also planning 175 villages program in Kalahani district in Orissa also. So we are roughly around reaching a scale of 400 plus villages with primary health center and hospitals. Now, we are able to do this in the last 4-5 years. The only parameter what we see is that if you put the health worker and the healthcare delivery process as a system and standardize that, and then you see the results coming out. So that's where you can expand much faster and better. Now, coming to is like how we address the problem. Now, what we are seeing in the thing is that, yes, technology is there as an enabler, but also is the other thing which we need to look at is the medical devices growth or the technology growth from the devices, because there's a hand in hand which is already important. If you see simple technology like from going from plain voice to data to 3G today, in the last 3 years there's been a rapid growth. If you go back 3 years back, even a simple phone at the village level was difficult. Today you see all this is available. So there's a trajectory of movement of technology. So is a trajectory of medical devices moving towards home healthcare, towards telemedicine, and much more peripherals. We had peripherals of medical devices with desktop. Now you see in the next span of 6 to 18 months, you'll have medical devices which could be integrated with mobile devices. So I see is that when you're serving the bottom of pyramid, you need to see the solution from 2 fronts. One is technology, medical devices, and the solution. The solution is in the healthcare delivery process. Now, if you're able to integrate this, I think we'll be able to address the problem to a larger extent. So I'll just take you through some of the things which we are doing, because we heard a lot from the other speakers. What we are doing in terms of solutions and how we are trying to bridge the gap, some of the application of technology. Now, in the microinsurance, we are doing a program with United Insurance Company based Chennai. We have launched a program with an hospitalization cum OP product, outpatient services, where the health worker would take care for the outpatient services, and the hospitalization would be taken care by the hospitals which are outside the network. But the enrollment process would be done through a mobile phone, the whole registration process and everything. So you cut down on the cost of actually sending the paper, taking a family photograph, which is mandatory from an insurance. So the technology comes in handy by actually the health worker doing much more quickly and sending this across. So we are planning to enroll around 10,000 policies in the current next 6 months for this program in Andhra Pradesh. Next is the application this is the program what we're doing in Maharashtra, where we actually given a handheld device to a health worker. In the handheld device, a biometric card is given to the patient, and the patient data is recorded. We are writing a microinsurance program in this thing. So you know how much balance is left, the patient names and details and authentication. And the health worker is being trained to operate that device, understand the whole history, patient history stored, and the data is synced to the backend doctor. So what you see is that with the use of handheld device and authentication, one, you're able to integrate a health financing, a microinsurance program, but also you have data available at the backend in terms of the patient record, which is normally done by the doctor. And we also built in a decision support system for guiding the health worker in the whole process. Yeah. Fine. So the apps basically looks into patient treatment, decision support system, how it could enroll people, and it can also take transactions and survey. The survey scope is basically understanding the patient experience. So just talking on the patient experience, we had is that we normally ask people what they feel about the services. So most of the things in terms of behavior change and understand patient experience, they are both related. For example, we asked and the patient feedback came is that your services are good, but at the same time the old woman says your services are bad. Why? Because you don't give injection. So the community is used to injections and used to by informal providers. To change that system, it's difficult, but it takes time. It's not difficult, impossible, but it takes time over a period of time. Now, how would you do that? Now, the only way to do is that by educating them is that the root cause of the problem is why people take injection, because they want to go back to the farm the next day itself or immediately after 2 hours. So injection is the best thing which actually the informed providers give. How would you solve these problems? You can only solve problems if you can give alternatives to it. Now, they want to get back to work. If you can give you a simple vitamin and ask him to take, it will actually give him the energy to work much faster. It's not about injection. Or you may give him a tonic, which may actually give him the same energy. If you can educate and give alternatives, that may change the health behavior. Now, this comes from the patient experience which we are tracking. Ultimately, the patient wants is somebody who can guide and advise and also guides in the right way. So that's what we have seen. This is our launch of our biometric card. Now, this is what we spoke about the video consultations. Now, we have started using our video conferencing basic desktop services, where we are connecting our two specialist services right now, a gynecologist and a diabetologist. What we are seeing is that it's not just plain problems of primary care which are affecting the issues, it's your actually chronic care which are actually on the rise in terms of hypertension, diabetes, and cholesterol, and it's seriously impacting the whole program. Then we have tested a mobile ultrasound in the early year, this year, and we have seen it's been a 3-month pilot testing being done at the hospital itself before taking the village level. What we've seen is that the product or the whole system, it's quite good and it's applicable. But the thing is that the utility at the field level in terms of transmitting the data, that is one. How user-friendly is the mobile ultrasound? Third is the legal issues. Now, we need to confront on all these three, and a policy change is required because a radiologist can't be there everywhere to do a mobile ultrasound. But you have technology available. So this is also one of the paradigm shifts which needs to be done if we actually want to serve the poor at the bottom of pyramid. You have technology, you have medical devices, but you can't really apply. ECG, which we know standard, it has become a norm now. Most of things could be done. We have done a manual-based fetal Doppler of fetal heart rate of the pregnancy mother. Now, currently, we don't have system of transmitting that on mobile or any data capture device, still in development. But we have done a manual way, and we see how you can actually bring around change in outcomes. And we have seen positively people come forward and check whether they're in a healthy place or not. Now, if you see from a public health system, how the A&M does, how you can compare the results, so on and so forth. So there needs to be a shift in the technology and how it could be taken up. These are some of the programs which are looking at. One of the most common problems is asthma. So how would you screen people for spirometry, how you can do it at a village level, and how you can actually transmit to a pulmonologist. How you can do echocardiography at the village level, how you can build a center, how you can do it. Currently, we are doing it at a hospital level with Mehboob for the last 8 years. But we want to go a step further and see, can you do it at a cluster level or block level? How you can integrate these things? How you can do a cluster-based or block-level lab tests, which are basically very much required to test. Currently, we're testing anemia, glucose, or cholesterol. But further going, how you can bring around a panel of tests for basic communicable, non-communicable disease. So the idea is that if you can look from, as I said, the address is the solution, again, is to go back technology, medical devices, and the healthcare delivery system. I would just want to tell is that one outcomes of our program in Maharashtra is that we have done research with Harvard and Monash University from Australia. The results very clearly says that if you do a prevention program, that is if you give hand washing soap, if you give a bed net or a water boil like a chlorinated water drop, and if you do it very well, it will reduce your hospitalization by 1.5 days. That is one. And the second thing is your expenses would come by rupees 550. Now this has been done a period of 3 years, and we're able to show it very significantly is that if you do primary care, if you do prevention, you can reduce the burden on hospitalization. And as I said earlier, you can do 70% of the primary care at village level itself by actually training health workers. So I just want to say thank you and end here.